Good afternoon, everyone. I want to welcome you to today's UCSF Family and Community Medicine Grand Rounds. We have a wonderful presentation today that I'm really excited about. As a reminder, today's session is recorded. And if you'd like to see today's session again, or if you missed previous sessions, you can look for us on the UCSF Family and Community Medicine website. Also, we have a feedback form that goes out about this session as well as all previous sessions. And if you have suggestions for our presenters today or suggestions for other Grand Round speakers that you'd like to see, please go ahead and fill that out. We'll have that in the chat later, in the Q&A later in the session. Before we get started, I want to say a special thanks to our tech team, Benjamin Wallen, Erigo Mitchell, Roy Johnston, as always, have provided us with fantastic support. I really appreciate their help. Our presentation today involves 3 presenters, and all of them have said that they would really love to hear your thoughts and comments and questions. So please use the Q&A to ask questions or share your comments. It's down at the bottom of your screen, and we hope you'll be filling it out. So today's talk, which I'm really excited to hear, is an equity-first paradigm for healthcare, hard-earned lessons from the UCSF Health response to COVID. The UCSF Health COVID Equity Work Group was formed in November 2020 to address racial ethnic inequities in COVID-19 amongst UCSF Health patients, UCSF employees, and the San Francisco community. The Health Equity Division serves as the system's strategic and operational engine to advance healthcare equity. Today, members of the COVID Equity Work Group will describe the multifaceted interventions implemented to promote health equity in COVID vaccination. An evaluation of these efforts informed development of a new framework, an equity-first paradigm that helped ensuing UCSF health equity interventions for COVID test-to-treat strategies and mpox vaccination. Today's presentation will highlight both the progress achieved and the ongoing challenges in moving a large healthcare institution to make equity first a standard operating procedure. Our presenters today, who I'm really delighted to welcome, are Pilar Collins, Tasha Tolliver, and Kevin Grumbach. Pilar Collins is a senior organizational consultant in the Health Equity Division, Department of Quality and Patient Safety at UCSF Health, and also co-chairs the COVID Equity Work Group. Pilar has a keen interest in focusing on leading UCSF Health to define and operationalize an equity-first strategic vision and framework. Prior to her current position, Pilar worked in information technology at UCSF Health, where she was the manager leading UCSF Clinical Systems customer engagement applications team, supporting new technologies at the Mission Bay Hospital. Prior to that, she was the information technology program manager on the Mission Bay Hospital's project construction team, where she led multiple infrastructure and applications teams. She has both a master's degree in public health and a master's degree in social work from UC Berkeley and is a certified project management professional. Tasha Tolliver is manager for UCSF's population health outreach team, which focuses on closing care gaps. Prior to this position, she was the operation manager for UCSF's COVID hotline, which was created at the beginning of the pandemic in response to the pandemic needs, and won a UCSF Health Pride Team Award in 2021. She originally joined the Office of Population Health in 2014 as a care navigator with support program. She holds a master's degree in health education from Kaplan University. Tasha has a passion for diversity, equity, inclusion work and is presented at UCSF's Town Hall on health equity interventions. Kevin Grumbach needs no introduction. He is still a professor of UCSF in the Department of Family and Community Medicine. He served as the chair of UCSF's Department of Family Medicine for nearly 2 decades and as vice president for population health for UCSF Health from 2015 to 2018. He co-chairs the Health Equity Work Group at UCSF Health. He is a founding director of the UCSF Center for Excellence in Primary Care and the director of the Community Engagement Program for UCSF's Clinical and Translational Sciences Institute. Kevin cares for patients in the Family Health Center at San Francisco General and also at Lakeshore Family Medicine. I'm excited to welcome the entire team and delighted to hear their presentation. Thank you for joining us.
Thanks so much, Margot. I want to again welcome my colleagues Pilar and Tasha, who will be sharing in this presentation. I'm going to start off, so I think they will step back for a moment, and we will start to share some slides. And really excited to be able to go over some of this and get your input on where we need to go forward to do better on the equity front. So we are among the people working on the COVID equity work group for the UCSF Health system. So what we're going to go over today is sort of the establishment of this work group to address inequities, particularly racial and ethnic inequities in COVID. And we initially focused on patients who get their care at UCSF Health, and then it expanded to include UCSF employees, including members of our own department, not just UCSF Health employees, and then some activities with the broader San Francisco community. And in the first year, the interventions really focused on COVID vaccination, and that's what we're going to talk a lot about. And we will describe the interventions we pursued and then some information about the outcomes. Out of this, we developed, and really Pilar was the kind of guiding visionary behind this, an equity first paradigm that was distilled from our lessons in COVID equity work in this health system. So we're going to go over the elements of equity first as a model for how to really center equity in all healthcare organization operations. And we'll talk about how we use some of those lessons to address emerging public health issues, more recently including Mpox vaccination and then the test to treat access for people with COVID. And then we'll conclude by offering some reflections on the progress we made and the continuing challenges to really institutionalize equity first as a standard operating procedure. Let me start by orientating our audience a bit to UCSF Health, because I know many people work in different health systems. Some of you are not actually people who are healthcare workers, but are involved in other aspects of activities in the department. So we are the Department of Family and Community Medicine in the School of Medicine at UCSF. And the school provides physician staffing to 3 large health systems in San Francisco, among other systems. I think most of you know San Francisco General Hospital within the San Francisco Health Network. We have a lot of clinical activities in the department, but we also have quite a few people working in the Family and Community Medicine department who are clinicians at UCSF Health, and UCSF Health includes now the affiliated Benioff Children's Hospital in Oakland. There's the SFVA, where we do not have many people in the department working, but hope to forge some closer ties in the coming years. And then there's other systems. I know we have Susan Hughes here from UCSF Fresno, and so we have connections with UCSF Fresno and various other health systems. UCSF Health is a very large system. Traditionally, it's been tertiary care focused, but has increasingly understood it needs a strong foundation of primary care. So there's over 200,000 active patients getting primary care, or some of them getting regular specialty care, even if they're not getting their primary care at UCSF Health. So that's a large number of people. And the majority of those active primary care and specialty care patients are actually from Black, Indigenous, and people of color communities. You can see the most prevalent racial ethnic groups among those BIPOC populations who are in this active patient population. It really reflects the diversity of San Francisco and the Bay Area. And 1 out of 10 patients receiving care at UCSF Health has limited English proficiency. So clearly a need to consider equity within this context. And again, equity has really been baked in as central to the missions of healthcare organizations like the San Francisco Health Network, the San Francisco Veterans Administration, but it has become recently a more intentional goal at UCSF Health. As Margot mentioned, the Health Equity Council was established in 2018, and Pilar and I serve on that Health Equity Council. That council does things like develop True North scorecard equity goals for the health system that focus on equity needs. And one of them for the past couple of years has been equity in COVID vaccination. We established a work group to then focus on this that Pilar and I chaired beginning a few years ago. And Tasha is one of the key members of that work group. And the work in COVID equity has included many different operational units within UCSF Health. One is the Division of Health Equity in the Department of Quality and Safety, which is the unit in which Pilar works. There's the Office of Population Health, where Tasha works, and I have a role in that. And then there's a whole bunch of other units at UCSF who have contributed to this work. So let me take us back in a bit of a time travel and go back to just remembering the arrival of the COVID pandemic in the San Francisco Bay Area and California in early 2020. And when we first pulled data on COVID and how it was affecting patients who are cared for at UCSF Health by race, ethnicity, this is what we found. So this is from the early phase of the pandemic, and similar to what was happening in San Francisco and California at large, you can see Latinx populations were extremely disproportionately affected by COVID. These are data on hospitalizations, and what it compares is racial ethnic groups as a percent of the overall UCSF Health population, and then as a percent of those patients hospitalized. So you can see Latinx, and this is the adult population, were 12% of our overall active patient population, but 40% of the people hospitalized. You see a slightly higher rate for Black African Americans at this time. So this really prompted the sense that we need to have a team come together and really think how we can address these really alarming inequities in COVID's impact. So at this point, we were starting to see the arrival of the vaccinations. Our COVID equity work group formed in 2020, and the vaccines were authorized starting in December of 2020. And so our initial projects focused on vaccination. Again, we had some signals early when the vaccines become available that there were pronounced racial ethnic inequities in who was getting vaccinated in San Francisco, and a preliminary look at UCSF Health patients. We also then realized we wanted to broaden it beyond just racial ethnic focus groups, but low-income people that were served at UCSF Health. So we used Medi-Cal enrollment as a proxy for low-income status and focused on all San Francisco Health Plan patients getting care at UCSF Health. We then realized we need to go beyond just patients at the system and start collaborating with community partners on broader vaccination efforts. And then we noticed there were some of the same racial ethnic disparities among UCSF employees in vaccination. And so that also became part of our charge of the work group. Our work group framework initially was informed by some work that many members of our Department of Family and Community Medicine were involved in. This was a publication from the Stop COVID work group that included Abby Cabrera, Lydia Leong was on it, Jonathan Butler, me, close colleagues like Alicia Fernandez from internal medicine. Alicia was also a critical member of our COVID equity work group. And we want to make sure it was not just focused on what we call individual resident readiness. There was a sense of people were talking a lot about vaccine hesitancy, and there was a bit of blaming people for not getting vaccinated. And we got a lot of input from the community that it was largely around vaccine access and the difficulty many people from marginalized communities were experiencing in obtaining vaccinations. You can see in this bottom part of the graphic a high barrier system, which is where a lot of the vaccination work started. You know, like in San Francisco, there were large drive-in mass vaccine sites that provided barriers to those who didn't have a car. A lot of the scheduling was online, and so if you weren't, having internet access or digitally facile, it was really difficult to get scheduled. There was a shortage of vaccines. It was you had to scramble and be first in line to get scheduled. A lot of it was only in English. So that's what we heard. And so part of this message was, how do we make UCSF Health a more system-ready organization to meet the need, particularly of marginalized populations? And here's some data just to put some numbers behind this. This goes back again to February 2021, when vaccinations first were becoming available to older people. And what this shows is the percent of UCSF Health patients who had active MyChart accounts, the patient portal, as of that time. And what you can see, again, 2/3 of white patients had MyChart active in the older group, and you see much lower rates of MyChart activation among these other racial ethnic groups: Black, African American, Latinx, Native Hawaiian, Pacific Islander. And again, you see a big gap based on English proficiency and limited English proficient patients. So here again, when vaccinations became available, a lot of the push was to schedule through MyChart, which immediately disadvantaged people from these social groups. So I'm going to now turn it over to Tasha, who's going to fill you in on the interventions we implemented to try to mitigate these inequities. Tasha.
Thank you, Kevin. So I'm going to talk about some of the key elements of interventions that were implemented. We developed a multi-pronged strategy for reaching equity populations, including using our automated calls and manual calls. What we soon realized that we needed to develop different approaches to reach our patients other than just through MyChart. We use cipher calling, which allowed us to efficiently reach large numbers of patients with a single intervention and to gather information from patient responses that gave us better data on their actual vaccine statuses, especially when we were experiencing data lags from the CARES data. It allowed us to hear directly from our patients about the barriers they were facing and the reasons they had for delaying getting the vaccine. We also determined that in order to reach some patients, we needed to do direct calls to allow for a personal one-on-one conversation that often surfaced the fact that many patients didn't know that they were eligible to schedule a vaccine at UCSF. We were able to schedule appointments for them as well as for their entire families. Some patients needed to have that human interaction to really fill the gap and make an appointment. Second is our warm transfers to OPH staff to schedule vaccines. We partnered with San Francisco Health Plan Multilingual South Outreach Team for them to make direct calls to UCSF Health SFHP unvaccinated members and perform warm transfers to our UCSF OPH schedulers and healthcare navigators who could then schedule vaccine appointments. Also, we use a high-touch calls from primary care physicians to our SFHP patients. We assigned primary care providers to make direct calls to their own remaining unvaccinated San Francisco Health Plan African American and Black patients. We also scheduling primary care visits for an unpartially vaccinated San Francisco Health Plan patients. We placed a note in their Apex chart for the assigned primary care physician to remember to engage in a vaccine conversation during their wellness visit. We also held employee webinars. There were two webinars hosted by BIPOC clinicians and Vice Chancellor Dr. Renee Navarro, which were well attended and allowed employees to anonymously participate and ask questions about vaccines and COVID during the FAQ period. And lastly, our vaccine information pop-ups. These were small groups and individual educational sessions led by BIPOC nurses to answer questions and provide information to employees still considering their own vaccine options. Additional interventions around language access and anti-racist framework. So other key interventions were geared towards improving language access and addressing barriers created by structural racism, including our UCSF Health website translations, working with the marketing team to translate COVID patient-facing web pages into multiple languages. Also using our COVID hotline, multilingual staffing, ensuring callers that were directed to the COVID hotline could speak with our nursing and scheduling team in the language of their preference. Our multilingual discharge instructions. This involved translating discharge instructions into multiple languages. And lastly, addressing structural racism and the trustworthiness of UCSF and health institutions when reaching out to the unvaccinated by providing tip sheets and framework to our clinical teams to support these critical discussions. We also provided convenient access. Most importantly, we needed to ensure we were providing convenience while expanding capacity. Some of our efforts in this area included establishing a vaccination sites on the UCSF campus and partnering with local community pharmacies. These sites offered extended hours for off-shift workers, weekend appointments, and reserved equity appointment slots for our patients, as well as integrating vaccine administration during primary care visits and cancer center infusion visits to increase both convenience and expand capacity. And I will hand it back over to Kevin.
Great. Thank you, Tasha. So what what did we accomplish? So here are the data on vaccination rates. This is among people 65 and older that are, again, the active impaneled primary care and specialty care patients at UCSF Health. And here's the signal we got when we were first starting our interventions. Now, again, this is when vaccines were just becoming available in short supply. But, we already got the signal that you could see, white patients, 8% had already gotten immunized, and that was about twice the rate among Asian, Black, and Latinx patients. And then in April 2021, when we really started implementing a lot of the measures that Tasha just talked about, we still had fairly prominent gaps. You can see here again, Black African American, about a 13% gap with whites, the Asian gap had closed, some Latinx and Pacific Islanders still low. And then by February 2022, and these are, again, I'm showing you the primary vaccine series, and we're going back to spring of this year when we really were sort of wrapping up this big push around primary vaccination. You can see the gaps had closed a lot for many of these groups. You now see actually Asians and multi-race groups were the most likely to be vaccinated. There was still a bit of a gap between Black, African American, and whites, or these other referent groups, but much less of a gap than we saw back earlier in the year. Still a lag in Native Hawaiian Pacific Islander, and that was one of our reflections that we did not do enough to really emphasize our outreach to that population. But again, I think we say gains were made in closing some of those equity gaps. Similar trends we observed based on stratifying patients by English proficiency. Blue is English proficient, orange is those with limited English proficiency. You see a huge gap, again, small numbers of people vaccinated, but a relative more than twofold difference. To start off, it closed a bit. By February, it had gone again from 15% gap to a 10% gap, still a gap, but certainly less pronounced than in the earlier phase. These are data on our San Francisco health plan patients. This is then all ages 12 and above, so not just the older folks that I showed earlier. And again, what you can see is here, huge gap, particularly for Black African American patients in this particular cohort of patients in August of 2021. You can see, the gap closed. Our goal was to get everybody in each group, at least every group, to 70% vaccinated. You see all these groups hit the 70% goal, but still not in Black African American. Again, a 20% increase, but still some, I think, some problematic gap there, although certainly less pronounced than it was earlier in the pandemic. UCSF employees, again, this includes, this is those of you who are employees of UCSF Health, you are represented in these data, and you could see same kind of disparities early on when the vaccine was just started getting rolled out and all health workers were eligible. You can see these, same types of racial gaps, particularly for Black, African American, Native Hawaiian, Pacific Islander, a bit less for Latinx. And by October, again, this is when it was required to get vaccinated unless you had a medical or religious exemption. You can see, very high rates of vaccination, still a bit lower among Black and African American, although again, relatively a closing of the gap, and most of these individuals have gotten exemptions for the requirement. Now, I want to just contextualize this. We think the interventions Tasha described contributed to some of this reductions in inequities. There was certainly a lot of other things going on at UCSF and in San Francisco and our partnering organizations that contribute to this. So by no means do we think whatever gains were made were because of just our COVID equity work group, and that these are part of a larger ecosystem trying to address disparities. The other thing, though, we realized is we needed to move beyond just thinking about a population of patients that we were accountable for in a healthcare organization, really think more broadly about how we could contribute to public health efforts to meet the needs of marginalized populations, whether or not those people were active patients at UCSF. So we started using UCSF Health personnel and resources to partner with community-based organizations, the health department, other coalitions you can see listed here, to start doing vaccine administrations at community-based sites. And I'm going to turn it back to Tasha to particularly describe the effort that went on in the Tenderloin with Grace and the Code Tenderloin CBOs and other groups to reach unhoused populations and others in need in that neighborhood. So back to you, Tasha.
So here's a highlight of some of our community events that we participated in. So we have a wonderful interdisciplinary team partnering with organizations in the Tenderloin neighborhood on a twice-a-week vaccination events with Erin Carrera, who is our UCSF team lead. We also have a vaccination event has been held every Saturday starting in May 2021 in Bodecker Park, where this beautiful mural is located. Hope you all have been able to check it out or will check it out. On Saturdays, the vaccinations occur near our Glide Memorial Church. And as reported in the front page story in the San Francisco Chronicle, one of the key strategies to reaching unhoused people was to include roving teams to meet people where they were at in the neighborhood and not requiring them to come to the vaccination sites. And next, here's a bit of data to show you from July 2021 to date. We have administered thousands of COVID vaccinations through the Tenderloin and other community-based programs. 80% of the people vaccinated are individuals from BIPOC populations. Lastly, our community teams are incorporating mpox and flu vaccinations into these events as well, now offering test to treat medication for any individual having a positive COVID test and desiring treatment. We have welcomed the opportunity to expand our operations in population health beyond just our own patients at UCSF Health to serve the broader community. And I will pass it to our very own Pilar Collins.
Thank you, Tasha. Today, I'd like to share with you the Equity First framework. The framework evolved from the COVID Equity Work Group that Kevin and I both co-chair, and a report that was issued in March of 2022 on the goals, accomplishments, and lessons learned from our experience leading COVID disparity work for patients, employees, and community. The report issued specific recommendations for UCSF Health that would support a paradigm shift to an equity-first model. As Tasha and Kevin have illustrated, historically, our efforts to address health equity concerns have been what I refer to as a cycle of playing catch-up. For COVID, as each new wave of vaccine supply and patient eligibility rolled in, there was a mad dash by UCSF teams to meet the surge in demand and provide immediate access to appointment scheduling. This standard approach to surge planning relied heavily on bulk messaging and online scheduling via MyChart, when we know we have significant disparities in MyChart activation for our patients. This approach predictably resulted in the most privileged, tech-savvy, and engaged patients getting those limited appointments, and leaving behind again and again the marginalized populations who may be harder to reach, less engaged, or facing a digital divide, or other barriers to access, and understandably feeling less trusting of healthcare institutions where they often have experienced discrimination and racism. The Equity First model that I'm introducing offers a way to do things differently and get in front of these known disparities. The 7 key Equity First recommendations provide a starting guide for how we can take action, or what we refer to in the first recommendation as disrupting the equity equation. This will require an intentional investment in equity, providing the resources and funding to support achieving equity gains, and most importantly, sustaining those gains over time. It will require working collaboratively to challenge our status quo and standard operating procedures, to appreciate how these may be compounding existing disparities and or creating new disparities in access, experience, or clinical outcomes. Central to an Equity First model is data. Our strategies must be data-driven, and not having access to dedicated, available equity data analysts to inform our interventions, monitor our progress and trends, and help us to understand outcomes has been a constant gap for us. and has often disrupted momentum and left us in the dark on the impacts of our efforts. Having built an approach to address health equity concerns that ties together employees, patients, and most importantly, community members has been a defining factor in the work. As Kevin briefly touched on earlier, embracing a public health model of population health provides essential collaborative partnerships with community-based organizations and other health entities. Finally, Equity First requires that we broaden the inclusivity of health equity improvement efforts to include, for example, other aspects of social marginalization, such as gender and sexual minorities or socioeconomic classes. Equity First is a shift in perspective to a more inclusive one. It challenges us to apply an equity lens from the start of all of our planning efforts. It relies on us to take a pause and to allow for consideration and elevation of the concerns and needs and priorities of our patients, employees, and community members who have been marginalized by systems of oppression. It allows us to mitigate harm of potential unintended consequences and emphasize the goals of equity. It's a framework that requires individual, systems, and institutional change. A key component of Equity First is making it a part of our standard work. Achieving equity is not ad hoc, one-off outcome, but rather a process change that requires time, investment, and constant focus to achieve and sustain gains over time. We have developed an Equity First playbook that provides detailed checklists for aligning leadership, allocating resources, leveraging equity advisors, developing action plans, and reporting outcomes. Next, I'd like to provide a few practical examples of our initial efforts to apply the framework. In each example, I'll show the prior state and then the current state after the framework has been applied. The first example references UCSF Health's COVID information web pages. At the beginning of the pandemic, these pages were produced in English only. Translations were by special request and required a long lead time. There was no mechanism in place for equity advisor review or feedback. And after hosting collaborative sessions with marketing and communications and equity advisors from both the COVID equity work group and the Division of Health Equity to introduce the Equity First concepts and the operations playbook, we now have many COVID information pages supported in multiple languages. Another great stride has been the commitment to simultaneously update the translated pages when the English versions are updated. I'd like to highlight the collaborative partnership developed that now ensures equity advisors have the opportunity to provide feedback and guidance on language accessibility. Next, I'll turn to vaccine operations. In this example, before integrating many of the concepts associated with Equity First, equity improvement efforts and vaccine ops were completely in different spheres and would come together in high-level steering committee meetings to report out. Now, we hold integrated work groups to align efforts and develop equity action plans to support our outreach interventions. Initially, appointments were required for vaccines. Scheduling was through MyChart. Vaccine site hours of operations were standard workday hours, and the focus was primarily on patient and employee appointments. Now, after taking an Equity First approach, appointments are encouraged, but walk-ins are accepted. Equity appointment slots are reserved to support equity outreach initiatives. Scheduling appointments can also be made through the COVID hotline. Vaccine site hours have been extended to weekends and after hours when needed. And vaccines are routinely provided to patients, family members, and loved ones. We are also regularly providing vaccine supply to community-based organizations. Another practical example that demonstrates the Equity First framework is UCSF Health Primary Care. In the prior state, patients were referred to centralized vaccine sites or local pharmacies. Separate appointments were required for COVID testing, vaccines, and treatment, and discussions with patients regarding their vaccine status was inconsistent. Now, 9 primary care and 6 specialty care clinics offer vaccines in clinic. Patient vaccine status checks and conversations have been made part of standard work, and clinics offer vaccine pairing with flu shots and COVID test to treat. And COVID test to treat clinics have received training and support for prescribing antivirals. Finally, another area of progress is communications. Equity advisors are now embedded in patient communications planning to make suggestions for minimizing complex medical terminology and ensuring language accessibility, and collaborating with patient family advisory committees for guidance on automated call scripting. We have also made modest gains in the area of data, including piloting the use of SOGI variables in mpox outreach and using geocoding to geographically identify clusters of unvaccinated or partially vaccinated UCSF Health patients for hybrid community and patient vaccine pop-up events. And now I'd like to turn our attention to our most recent experience in trying to implement an equity-first model for mpox and COVID test to treat. As the mpox outbreak unfolded, we tried, but did not fully succeed in getting ahead of the curve to ensure that the equity-first model was applied at the very earliest stages. But we did make significant strides in realigning our model of outreach and delivery earlier than during the private COVID waves. In this slide, you will see that a review of the earliest data available on the first 199 doses administered, not surprisingly, showed significant disparities in both Latinx and African American Black populations. You will also note that this early data set did not include the SOGI variables. The COVID Equity Workgroup met following a review of this preliminary data and identified an opportunity to apply the SOGI variables for outreach in order to best identify eligible patients that may have otherwise been missed with our standard queries. At the very beginning of the mpox outbreak, the initial opening of MyChart appointment scheduling preceded any equity outreach or communications. And not surprisingly, we saw the built-in advantage at play for MyChart activated patients. The vast majority of the very limited number of appointments filled up immediately via MyChart and were secured by our most privileged and engaged patient populations. In order to address the significant disparities identified in the data, we once again had to play catch-up. To do so, we immediately reserved 25% of the appointments for equity. In collaboration with the Office of Population Health, we launched a direct outreach call campaign to priority patient populations, many identified from our specialty clinics, in addition to using the self-reported race, ethnicity, and SOGI data fields in APEX. We enabled the 360 clinic, which serves primarily people living with HIV, to make vaccine appointments for their patients directly. And we also provided vaccine supply to our vaccination teams in the Tenderloin and other community groups. Turning to the data, you can see that in the first couple of weeks, there was very low representation of Black, African American, and Latinx individuals among those vaccinated. For example, the Black African Americans were only 2.9% of those vaccinated. However, in the next 4 weeks that followed, after we started to implement the Equity First approach, there was some progress made with Black African Americans, showing a 68% increase from 2.9 to 5%. And for Latinx, showing a 47% increase from 9.8 to 14.4%. For the most current analysis, as of September 12th, there was significant progress in reducing but not eliminating disparities in equity-focused populations. Because we used the SOGI variables to help guide our outreach, this data confirms that we were reaching the populations at most risk, with almost all recipients of the vaccines being from sexual minority populations. And now we will look at our experience with implementing an equity-first model for COVID test to treat. Our outreach campaign included the following elements: a multilingual automated broadcast education message launched via Cipher to our equity-focused population, a postcard mailer, and community antiviral distribution, and a collaborative effort with Office of Population Health to secure a 1 million CDPH grant for COVID test to treat. I won't show the data. However, not surprisingly, we saw the same pattern of disparities of who was and who was not gaining access to antiviral treatment in the test to treat outreach efforts. Similar to mpox and our experience with piloting the use of SOGI variables, these efforts, in order to be successful, require a lot of analytic support and resources, which we are still struggling to secure. I hope that these examples that I've shared illuminate for you the modest but encouraging progress that we've made in shifting to an equity-first paradigm. Yet we recognize we still have far to go, namely making the commitment to fund sustainable positions with health equity-focused roles and assignments. Without the data, we cannot see where we are going or where we've been. As referenced in the MPOX and the SOGI pilot examples, as well as for Test to Treat, we keep running into the same roadblocks when having to ask others to help out on an ad hoc basis to fill the gap of not having dedicated equity analyst resources. Though some progress has been made with the extension of UCSF Health community vaccine funding and a strengthened commitment to consistent executive stakeholder presence in community forums and working groups to build on partnerships and offer UCSF Health resources to supplement community efforts, we still have work to do in this area. Fully shifting to an equity paradigm, although leadership is engaged and actively voicing an equity-first approach and making strides in understanding what that means and what would be required to sustain this model and integrate it into standard work, funding and resources challenge the viability of this commitment. The progress we can see at this point is with individual allies who are embracing an equity-first perspective and weaving it into a part of their everyday culture, language, and thought process. Where the greater challenge remains is integrating this change into the systems, infrastructure, and ultimately the institution itself. All of this work that Kevin, Tasha, and I are sharing with you today has been made possible by a unique team of dedicated, innovative, and resourceful individuals to whom we extend a tremendous thank you. Now I'll turn it over to Kevin.
Hello, and Tasha, come on, why don't you join us, Tasha and Pilar? Let me thank Tasha and Pilar for just doing such a superb job in collaborating. I also realized a couple of thank yous I needed to add. One, I mentioned some of the team on the project that had come up with the individual and system readiness. Roberto Vargas has also been a critical member of that team. And I also, we want to make sure people understand there are other healthcare organizations that have also done tremendous work in this regard. Again, San Francisco Health Network has really been a leader in this. I want to give an acknowledgement to Ariel Franks in the Department of Family and Community Medicine, who helped lead the equity efforts for San Francisco Health Network. Had a wonderful article she co-authored in New England Journal of Medicine Catalyst describing some very similar types of approaches in that system. And I know many of you in other settings are also pursuing these things. But, for UCSF Health, I think this has been a major shift. As Pilar said, we have a ways to go, but to really get that particular large healthcare organization to put equity more centrally in its work and move closer to an equity first operating model. So I think that's where we are. I don't know, we're open for questions from the audience. If people have any questions or comments they'd like to contribute about some of their experiences, how they kind of understand this to play out as this journey of institutional change that I think we're all on to make institutions much more centrally focused on equity. Let me see here. Let me look at a Q&A from. There's a question, Pilar, maybe you can help with this one. I think we talked about equity advisors several times in the presentation. Who are they and how are they compensated? So Pilar, can you talk about when you talked about equity advisors working, for example, with a communications team and things like that? Yeah, what are you saying about who we're referring to and how they're supported?
Well, I think that's one of the central points of the presentation is that really a lot of the work that the COVID Equity Work Group has done in partnership with many other departments has been folks really flexing out of their roles, their standard roles and their, quote unquote, real jobs, and doing work that they're passionate about and providing support to the COVID Equity Work Group. We do have equity advisor consultation available through the Health Equity Division. And then the Health Equity Advisor roles have been filled by a lot of folks who are on the COVID Equity Work Group. This is not any special compensation outside of their traditional roles in their jobs. So that's one of the things that we're really looking to the institution to do to fund equity long-term and make that investment in the equity portfolio.
And some of this actually, the genesis of the Health Equity Council at UCSF Health actually grew out of the UCSF School of Medicine Differences Matter initiative, which many of you are familiar with. And there were actually 3 Differences Matter leaders, Alicia Fernandez and Michelle Johnson from the VA and Malcolm John from UCSF Health, who were in charge of the subcommittee that said we really need to start moving some of the equity and DEI work more centrally in these 3 major health systems. So that was part of it. And so we had some real experts who were very well steeped in equity and diversity issues, such as Alicia and Michelle and Malcolm, being part of the work group early on. So I think it was how to identify people. Again, it comes with some folks with the usual minority tax. If it's not compensated, some of those folks were compensated as part of the Differences Matter work, as well as some staff. But I think that's the ongoing challenge, is to make sure this is seen as part of people's funded effort and not just we're taxing people, particularly folks from marginalized groups. Question here from Carolyn about, can you say more about the equity data challenges? Does UCSF not already analyze its data by race, ethnicity? Well, Pilar, maybe I'll start a little bit with the whole basis of having race, ethnicity data, and then as Pilar and Tasha talked about, we also started having more self-reported sexual orientation and gender identity data. So, you know, very similar again to San Francisco Health Network. It was a very much a hodgepodge in the electronic medical record of people's identities. And you never were quite sure whether patients had been asked about their gender or their race, ethnicity, or was a registration clerk who said, oh, Kevin, you look white and I think you're a man. I'm going to just fill out those demographic fields when I register you. Or maybe, some very cursory conversation. But there was a lot of missing data in the electronic medical record on race, ethnicity, and a lot of it was inaccurate. And there was a lot of concern it may not be actually people's own self-identities. So in both systems, there was an effort to start collecting much more systematically people's self-reported race, ethnicity using a series of questions that had very granular ethnic categories, in addition to some of the traditional large race categories. That was great. And there was a real effort to make the standard operating procedures and registration and clinic visits. And it also started including then self-identified race, sexual orientation, gender identity. Maggie Deutsch in the Department of Family Community Medicine, who's been a real leader in this field, was very critical to developing some of the processes for SOGI data collection. Then we had to realize, well, wait, now we have people with 36 different ethnicities in the database. So we created a whole algorithm to roll it up into something like 7 mutually exclusive categories. It now, for the first time, included multiracial ethnic. It didn't separate Latinx as a sort of separate ethnicity, and then you had race. But we created a whole algorithm. So a lot of this took a huge amount of work on the back end to really create meaningful, mutually exclusive categories for racial ethnic identities. Then once we had them, you then have to start using it for analyzing, like, who's getting prescribed Paxlovid, and how do we compare this now that we have these defined racial ethnic groups, for example. So then, Pilar, then you can explain, okay, then you get into challenges even when you have the data there in the database. It's not a trivial matter to produce reports.
Yeah, and I think it's partly having dedicated resources that are available when you need them, because the data has to be timely. And so you need to be able to anchor the interventions that you're doing to a predictable schedule of receiving data to get that feedback. And are we making progress? Do we need to refine our queries to ensure that we're really getting the population that we're seeking to reach? And we had an especially challenging process with MPOX, because it was the first time we were really piloting the use of SOGI variables. And so the first time out of the gate, we really didn't have the sophistication both on the data team as well as a full enough understanding of the variables to accurately identify the population. But luckily we were able to do another round, did another query, identified an additional 800 and plus eligible patients, and did outreach to those. So it's trial and error, and it's also step by step making progress. And I think of all the work that we've done and all the interventions, it's really brought to the surface how critical data is and how critical it is to having the data analysts integrated on the team from the beginning of the planning stages all the way through, and having access to that data.
Yeah, so I think it's one thing to say, oh yeah, can we do a quick run of looking at Mpox vaccines, for example? Yeah. Okay, now can we have analysts to really take all these detailed, let's say, gender identity variables and sexual oriented variables, which are multiple, because again, it's not just, gay or, there's bisexual, there's binary and non-binary, there's a whole lot of things in the different SOTI field. And then you have to say, okay, which of those maybe would put people in a higher risk group for Mpox, which we then want to prioritize. So I think there's an underestimation of, once you have the data, what it takes to really analyze, to have data that then generates information that has knowledge, and the knowledge that actually has wisdom that you can act on. Tasha, I'm also, sort of on the data, side, we rely so much on technology, and I think this has been, for sure, there's efficiencies in things like online scheduling on MyChart. I mean, all the clinicians know there's a mixed bag with MyChart, with the work that's then involved. But Tasha, was that experience with talking to people on the phone? How do you think that augmented what was done versus just sending messages out through MyChart or emails and things like that, in terms of the human interaction for people who were thinking about vaccination?
Absolutely. So what we noticed that, of course, as you know, MyChart is oftentimes not very patient or user friendly for a lot of people, for different steps. And many people we've identified, just even if they had MyChart, they didn't remember their password because they haven't logged in several months or even years. So when they receive that warm phone call from one of the schedulers or the navigators or the nurses to talk with them about, about them being eligible for the COVID vaccine, or just answering some frequently asked questions about, side effects and different things. Many patients were very, we had still had a lot of people that were hesitant, but it allowed them to be able to ask a lot of questions, to get a lot more informed information, opposed to what they were constantly hearing via the media or on social media. So to be able to have someone directly on the clinical team to be able to provide them good information was helpful, and they found it helpful. And it actually moved some people who may have been hesitant to receive the vaccine, that down the line, they ended up receiving the vaccine, after a little while. And then for our pediatric population, when we will call, a lot of those patients, the parents are not patients here at UCSF, but their children were patients here at UCSF. And when we called and offered their child to be vaccinated, and then offered the parents or anyone in the household to also be vaccinated, a lot of patients were very happy about that. They didn't know that they can do it as a family. So it was very helpful to be able to not just address our patients, but the families.
Spoken like a true member of, honorary member of family and community medicine, Tasha, with closing on that comment about a family-centered approach to care. So Margaret, it looks like we're time to wrap up.
It is time to wrap up, but I appreciate, this has been an incredibly inspirational presentation about how much work has been done, and also sort of inspiring for how much more work remains to be ahead of us. So I really love the framework that you gave. And I want to thank you, Tasha, Pilar, and Kevin, and give you the final word, although I love what Tasha said because it sounded so much like a family doctor. So thank you for those words of wisdom. And I hope you'll end us on a final note there. Thanks everyone for joining us.
Yeah, I think I would just, again, Pilar really did a beautiful job of creating this equity first paradigm. I actually think we should embrace it in the department and just, I think you realize every time you're thinking about an innovation or something you're going to do differently, it's a really great checklist to say, let's make sure we're building equity in from the front end. So it's everything from a new program to things like patient portals. It's just we're playing catch up too much, and I think we really need to make sure we have a very different way that I think we should think about in all aspects of the department, frankly, about equity first as the guiding model.
That's wonderful. Thank you. Thank you very much. And thank you to our presenters. Thank you for joining us today. We look forward to seeing you soon at the next Grand Rounds. Have a great afternoon. Thanks,
Thank
everyone.
you. Bye-bye.